Australia. I come from the first affiliated hospital of Guangxi Medical University, Department of Clinical Laboratory. Today, I'm going to share with you a rare case. A 16-year-old man with severe pneumonia caused by Ureaplasma, urea. The young man who comes to the doctor complaining that he developed repeat fever after allogeneic hematopoietic stem cell transplantations. When we took his clinical history, he told us he had beta thalassemia, so he received blood transfusion and iron removal since childhood. In 2019, he had undergone splenectomy. According to his clinical history, we know that he has immunodeficiency and had high risk for pulmonary and systemic infections. In the next 2 months, he continued to develop repeating fever. The bacterial and fungal culture were performed on his blood, urea, BALF, and other specimens, but the results were all negative. The doctors changed many antibiotics for him, such as ceftriaxone, sabaton, vancomycin, and flucytosine, and so on, but his condition comes and goes. So we must ask ourselves, why did he have recurrent fever? Is CMV virus infection or immune deficiency? If it's an infection, what's the pathogen and how to treat it? The turning point of our case occurred on 104 days. The doctor sent the patient's BALF samples to our laboratory, and we conduct the general culture, EB virus DNA, CMV virus DNA for him. Due to its condition was getting worse and its general culture was always negative, we sent his BALF to a company for MNGS test. 2 days later, the result came back. It's Ureaplasma, urea. In order to verify the reliable of MNGS results, we suggest doctor to add the blood ammonia, UU, DNA, and UU culture and germ sensitivity for the BALF samples. These results came out quickly. The blood ammonia, UU DNA, and CMV DNA were evaluated, and the culture of UU was positive. And the germ sensitivity results showed that the bacterium was sensitive to azithromycin, gelsomycin, and gatifloxacin, and resistant to levofloxacin and ciprofloxacin. At 107 days, his CT scan showed a thickened disorder, texture, and mosaic in both lungs. This tongue temperature curve clearly showed important clinical items for the patient. We could see after azithromycin used, his temperature was rapidly controlled and the inflammatory markers was decreased, such as CRP was decreased from 1917.86 to 2.44, and the serum procalcitonin was decreased from 0.344 to 0.76. However, he died due to the recurrent fever for nearly 3 months. UU is named for its ability to decompose urea. The chocolate and blunt agar come isolated due to its diameter was 0.05 to 0.3 micron. No cell wall colored by gram staining, so it is difficult to find it in microscope. In addition, it is a common parasite of human general urea tract. The lung infection of this pathogen is very rare. MNGS is a high throughput detection technology that can directly detect the nucleic acid in clinical samples. According to our case, we deeply feel that the clinic, microbiology, and pharmacy are inseparable. Only when the three departments forming entity of anti-infection cooperation can we save more patients' lives. That's all of my presentation. Thanks for watching.